Okay, so now let's finish Learning Plan 10. So the last part of this learning plan is looking at roles of nurses in different community settings. That is one of the competencies of the course. There are lots of different areas that nurses practice in, and so various chapters are going to be highlighted for each of the specialty areas, but you do not have to read all of those chapters because that would be an enormous amount of reading. It would be like, 9 or 10 chapters for this one learning plan. I just thought that was a little bit excessive. So just basically, it is a competency of the course to talk about and think about the role of the nurse in various settings. So I am highlighting school health, forensic, corrections health, occupational health, home care and hospice, and faith community nursing. Those are the chapters which the information comes from. However, again, you do not need to read 5 extra chapters. We're just really going to hit the highlights of what goes on in each of those specialty areas. And again, according to the competencies, we're kind of thinking about comparing and contrasting the role of the nurse in these different community-based settings versus the role of the nurse in a more traditional setting, such as a hospital or even possibly a nursing home. Well, especially the hospital, I guess, because in the hospital, when you're practicing as a nurse, you have other specialty disciplines working right with you. They're readily accessible. You have the pharmacist, you have physical therapy, occupational therapy, social workers, sometimes different medical specialties. So you have a lot of different people to work with, and they're right there, and it's very easy. Well, usually very easy to get a hold of people and have that ongoing communication. But when you're working in some of these other areas, like in the school system, in the jail, in an occupational health setting such as a business or a factory, when you're working in home care and you're making trips to people's homes to provide care, or if you are in a faith community nursing role and you're providing care for people of a church group, then you're kind of by yourself. You function much more autonomously than you do if you work in a hospital setting. So even in a hospital setting, you have other nurses. So if you get stuck on something and you don't know something, you need some help, maybe you just can't get that IV started, you've got people to back you up that are right there. So you can always ask a coworker to help you, and vice versa. You might be the one to be asked for your area of expertise or your special skill in something. But you don't have that in these various community settings. You don't have usually anybody else right there working with you. So that is really a huge change. So just that level of autonomy. You have to be really good at communicating to work in one of these areas because, again, because of that whole aspect of not having other disciplines, that ability to collaborate with your own discipline and other disciplines readily available to you. You've really got to make that effort to call, and you have to also be able to be very wise about when to call, when not to call. So lots of different things like that we can think about. Some of these roles can actually be a little bit lonely because you're the only one doing it, and you have to work a little bit extra hard in order to find the support that you need sometimes. Everyone has a stressful shift now and then, and when you're in the hospital, you have, again, coworkers that are right there readily available. But if you have a really difficult emotionally and or physically draining experience in any of these other settings, you really have to make sure that you find a way to talk to somebody and to kind of perhaps even debrief a situation with another professional who, of course, would keep confidentiality. That's always a concern that you might have. The other aspect of these community settings would possibly be delegation, because when you're in the hospital and you delegate you're an RN and you delegate to another RN, that's pretty much a level playing field. Or if you delegate to a CNA, you know exactly what their roles and responsibilities are. And sometimes there are things that might have to be delegated in some of these other settings. And so you have to really understand what you should delegate and what you should not delegate. So especially, we're going to talk about that a little bit with school health nursing, because there are some areas that that do end up being delegated. So we just have to be careful not to delegate any part of the nursing role. So school health, the healthy development of children and adolescents, is influenced by many societal institutions. After the family, the school is the primary institution responsible for the development of young people in the United States. And so that is a quote from the CDC, or the Centers for Disease Control and Prevention. So think about it. Where do children and adolescents spend most of their time? At home and at school. So that really certainly makes a whole lot of sense. So school nursing practice is a very specialized practice, and nurses need education in growth and development, public health, mental health nursing, case management, program management, family theory, leadership, and they have to have cultural sensitivity and have knowledge about the different cultural groups that they may be working with. So it really is a very comprehensive aspect of nursing. So academic success, it's impossible to achieve academic success in school without maximizing the health of the students. So poor academic performance is strongly correlated with uninsured status of youth. Acquisition of health insurance leads to an increase in school performance. So if kids are sick, they're chronically sick, they're not getting their health needs taken care of, they are going to miss more school, and of course not being there, even if they have makeup work to do, makeup homework or whatever, it's not the same. It's not the same as being there and going through the school day and learning in many different ways. Just being there sometimes is so very helpful. So how can those kids get through school and pass their grades and graduate eventually without good health? So health problems, again, leads to an increase in absenteeism, and the school nurse has a unique opportunity to make a positive impact on the nation's youth. One thing, though, that I think is interesting about the role of the school nurse, it does seem like it has evolved over the years, and I remember a long time ago when I was a kid, there would be a school nurse that actually physically was at every single school. And I'm not sure that that really happens nowadays. Sometimes the nurse is covering several different schools, and he or she may be covering hundreds and hundreds of students, and that's really a big job. It's really quite difficult to try to manage the health care, the health needs of all those students, and to really make sure that they have that academic success. So I really think that that is something that's a huge issue that school nurses face. There just aren't enough of them. I would think a big draw into, besides an interest in working with students, a big draw would be the schedule. You're following, basically, if you have children, you're following your kids' school schedule, and I'm not sure what type of work that they're that they do, if any, over the summer, but you would think that you wouldn't be needing to show up at a school over the summer, so perhaps there's work to do at home. But anyways, just lots of different things to think about. But truly, the school nurse does have a great opportunity to make that positive impact. So the school nurse should really be involved in health education. So some priority areas from the CDC would be alcohol and drug use, injury and violence, including suicide. And I would think, as far as violence also, I would think bullying would probably fall under that too. Tobacco use, poor nutrition, lack of physical activity, and then sexual behavior that results in STDs or unwanted pregnancies. And of course, some of these topics are meant for more adolescents, and some of the topics could be that you would think of would be more pertaining to younger students. So, of course, the priority if the nurse is working with elementary age children versus middle school and high school, the focuses, of course, would be a lot different. The school health nurse can provide emergency care, so schools may see minor school injuries to severe life-threatening events and mass casualty incidents. So the school emergency plan is developed by the school nurse. So again, a very key role in managing anything that's out of the ordinary that might happen. Children with special needs, special health needs. So in 1976, a public law was enacted, the right for severely handicapped children to attend public education in the least restrictive environment. So that really kind of paved the way for kids to be able to receive education at their local public school. So Education for All Handicapped Children Act of 73 and subsequent Individuals with Disabilities Act of 1990 said that children previously served in acute care and long-term care settings would have access to public education, and so the school nurse is also responsible for individualized health care plans. So that is something that the school nurse needs to develop as part of an interdisciplinary team. So there's a lot of collaboration that goes along with the role of a school nurse. And that individual health care plan is really set up to deal with whatever disabilities the child has and to really, again, try to maximize their potential so that they get through school and they may have a better chance at functioning in life a little bit better and with more independence and autonomy. There are school-based health centers, and that would be one of the best ways to offer a comprehensive health care to children and adolescents. So an interdisciplinary team approach is used with nurse practitioners, social workers, psychologists, physicians. I know one thing that is a big push as far as, again, I'm going to bring up mental health as often as I can, but there is definitely a push for having more mental health care right in the school, to have counselors and psychologists available right in school during the school day so that the parents don't need to take their child out of school for an appointment or try to fit in an appointment after school, which might conflict with a whole host of other things going on with the family. So it truly is a wonderful concept. Just not sure that it happens in every area. Don't know that we have any school-based health centers in our immediate Lakeshore district. So they work in collaboration with and among the families, the community, the education board, and with families. So, and again, we talked a little bit about delegation. That's something that's we really have to think very seriously about, because the school nurse may have to delegate certain tasks, because a nurse may be assigned to 3 or 4 different schools, and you can't be obviously physically present in all of those schools at the same time. So the nurse is responsible, but each state's Nurse Practice Act stipulates what can be delegated. So certain things like maybe medication administration or something like that possibly could be delegated. I have seen, when I used to volunteer at my kids' high school in the health room, I have seen some of the secretaries give medication to the students who had come to the office. Not sure how that exactly is worked out as far as them following directions on what to give, how much, what route, all that. But the only thing that the nurse really has to be very concerned with is that the responsibility for assessment, diagnosis, goal setting, and evaluation, so basically the nursing process, may never be delegated. And that, of course, is true in any setting. If you were in the hospital and you tried to delegate something to the nursing assistant that was not something that the nursing assistant should be doing, such as assessment, then that would also not be according to the Nurse Practice Act. So we do have to be very careful about what we delegate. All right, forensic and corrections health. So the term forensic means pertaining to the law or legal. So forensic nursing is defined as the application of the nursing process to public or legal proceedings and the application of forensic health care in the scientific investigation of trauma and or death related to abuse, violence, criminal activity, liability, and accidents. So there's a lot of different roles that we're going to be looking at that kind of fall under forensic nursing. So forensic nurses practice in multiple areas and settings in the healthcare and public health systems. So responsibilities might include screening, assessment and documentation of injuries and collection of evidence, expert witness testimony from victims and perpetrators across a variety of settings such as hospitals, community clinics, or death scenes, involvement in paternity disputes, cases involving workplace injuries, malpractice, transportation crashes, food or drug tampering, and medical equipment defects. So a lot of different interesting kind of things that they're looking at. There are a lot of different subspecialties of forensic nurses. So a sexual assault nurse examiner, I think I mentioned that when we were talking about in Learning Plan, I think it's Learning Plan 8, sexual violence, rape. The sexual assault nurse examiner has a huge role in helping the victim through that very difficult experience, and also, of course, helping them in being an expert witness and helping them in the court situation also. A medical legal death investigator could be I believe a nurse coroner can actually be considered part of the role of a forensic nurse. And so the nurse coroner would go to the site of death and try to make a determination if more investigation is needed, if the death was a natural cause or if there was something that caused the death that possibly could have been prevented. A medication error, some kind of an injury, a fall, anything like that, a coroner usually is called to make some kind of determination. So there's a forensic nurse investigator, legal nurse consultants, and nurse attorney. Now, to be a nurse attorney, obviously you have to go to law school. So you've got years more of education if you want to be a nurse attorney. But a legal nurse consultant, I believe, is only an extra course that you would have to take. So that extra education would not be a degree, but it would more fit in with professional development and certification. A friend of mine actually is doing that and just took some professional development credits and is able to function as a expert witness. So all of these roles, as we're talking about, I'm hoping that you're maybe thinking about, that's interesting, I'd like to do that someday. So maybe this will spark your interest in going into a particular area. So, okay, clinical forensic nurse examiner, forensic psychiatric nurse, correctional nurse, and forensic nursing educator or consultant. So, lots of different subspecialties. Correctional nursing is a specialized subset of forensic nursing in which the clients are inmates. So, that is the role of the nurse to take care of the health needs of inmates. The primary goal is to maintain a safe, secure, and humane environment for the inmates. And you have to recognize the safety and security issues for the nurse. And as I tell you in mental health, always maintain an escape route. So that would be a very important thing for the nurse to constantly be aware of their own personal safety. The nurse really has to understand the prison culture and that many times inmates do manipulate nurses, and the environment is also highly isolated. So the nurse really doesn't have a lot of people to bounce ideas off of, or if they weren't sure of their assessment, it's not like they can just get their buddy in the room next door like you can when you're in the hospital and say, hey, come look at this with me, I'm really not sure what I'm seeing. So that part of it's really very difficult, and it is extremely difficult when people are manipulative and they're perhaps trying to get medication, or perhaps trying to get out of jail. Maybe they're trying to get out of jail and into the hospital. So you have to think about, having really good assessment skills, because you are trying to determine if somebody is perhaps embellishing things a bit, or you really have to use good communication and also just very, very good assessment skills to really figure out if something is going on. I mean, we all hear horror stories about inmates having difficulties, they're having problems breathing or having seizure activity, or they're in labor or something, and nobody is kind of doing anything about it. So that would be, of course, the worst case scenario. So very, very difficult role for the nurse. There are mental health issues in correctional settings. Very surprising, I'm sure. No, you're probably saying, no, it's not surprising at all. Just think about being a mentally ill person, having a mental illness, and then trying to adjust to being in jail. It is extremely difficult for many mentally ill individuals. Deinstitutionalizing led to what amounts to is the criminalization of the mentally ill. There are so many incidences that I hear about where people, to me, clearly have symptoms of mental illness, and instead of going to a hospital, they're taken to jail. I've talked to the staff on 1K, what do they think about it, and why do certain people seem to go to jail versus coming to the hospital when they have clear signs and symptoms of a mental disorder? And it's just not, there's no clear line as to how that decision is made. So it's got to be very difficult. Think of if somebody is psychotic, they're hallucinating, they're delusional, they're just not in reality at all, and then to be thrown in a jail environment would just have to be horrible. So access to mental health treatment and medication is a right for prison inmates. However, I know just from talking to some friends of mine that work in these areas, it is very difficult sometimes for them to get the medication to get the right medication for their mental illness. So if they have attention deficit disorder and they really need their medication in order to keep themselves in behavioral control, might be really difficult to get those meds because they're scheduled and they are controlled substances, and they have a high probability of being abused. Sometimes, so they have to worry about the inmate cheeking the medication, stockpiling it, giving it to other people, all kinds of issues like that. So it's very difficult to get medications for anxiety, attention deficit disorder, and even some antipsychotics. They have a hard time getting those. Seroquel actually has street value. So if something has street value, for sure that an inmate might be, again, cheeking it and giving it to other people, selling it, something like that. So all kinds of things happen in a jail environment. So basically, they may not be getting the correct medication for their illness. Really depends on what the medication is and if it's allowed to be given to them. So that makes it really difficult. I know that there are times when patients come to 1K and we hear and report that they were in jail for a period of time and they were not getting their medication. So of course, when they leave jail, they're psychotic, they're hallucinating, they're not able to care for themselves, and they end up in the hospital. So really is a difficult situation. So, and nurses really have to be always aware of the vulnerabilities of people with mental illnesses who are incarcerated. Again, if they're having a hard time with reality. Also, if they are suicidal. So I know that there's specific protocols for people that are suicidal, but many times when they are suicidal, they're isolated. And if they're isolated from other people, that really doesn't help with depression and certainly doesn't help with their suicidal ideation. Yeah, jail is not an ideal environment for caring for, working with people that have mental illnesses. That's pretty much the bottom line. Okay, now we're looking at occupational health. So that specialty practice focuses on the preventive health care and health restoration within the context of a safe and healthy environment. So we're talking about safe and healthy work environments. So businesses, different types of businesses, factories may employ an occupational health nurse. So they have a multidisciplinary base. So again, looking at all of the areas we've talked about so far, a lot of collaboration. So think of CUSIN, a lot of collaborative care with other people, but those other disciplines may not always be right on site and easily available. That you may have to consult with them, make a lot of phone calls or emails, whatever. So the multidisciplinary base certainly involves nursing science, medical science, occupational health sciences, epidemiology, business and economic theories, concepts and principles, social behavioral sciences, environmental health, legal and ethical issues. So multidisciplinary teamwork is a very important aspect of occupational health. So these nurses work in a variety of settings, and often, again, they're the only on-site healthcare professional, and they collaborate with workers, employers, and other professionals. The roles are very diverse and complex. I know an occupational health nurse, and basically, well, I know a couple, but one in particular that I can think of, I asked him about his role once, and he basically said that his hands were tied in the particular company he was working for as far as really making an impact on the health of the employees. It sounded like his role was more dealing with injuries on the job, first aid, and just providing assessment and direct care for people that injured themselves on the job. But for whatever reason in that company, that his hands were tied as far as being able to make an impact in other types of areas. And I don't think that's true for all occupational health nurses. I certainly think they have a huge role in looking at and trying to keep the environment safe and helping to prevent injuries. That would certainly be a big goal, not just reacting and taking care of injuries, but trying to prevent them from happening in the first place. So their roles are diverse and complex. They coordinate comprehensive holistic services, and their practice is guided by the AAOHN's Standards of Occupational and Environmental Health Nursing Practice and Code of Ethics. AAOHN, standing for American Association of Occupational Health Nurses. I just love acronyms. Okay, anyways, so occupational health nursing really needs to include prevention of adverse health effects from occupational and environmental hazards. Super, super important. So if you can think ahead as to what might be hazardous and try to plan so that people are kept safe, that would be certainly ideal. They also provide and deliver occupational and environmental health and safety programs and services to clients. There are times that occupational health nurses can actually work with people on an individual one-on-one basis to even just improve their own individual health. So if somebody has high blood pressure, diabetes, or possibly like a repetitive work injury or something, they could really work with them too individually to try to improve their health status. And of course, everything that they do has to be within the scope of practice determined by state laws. And all state laws truly are different. So if you move to a different state someday after school, maybe you're going to work in Hawaii or someplace really nice, you're going to need to find out what the Nurse Practice allows, what the Nurse Practice Act allows in your particular state. So occupational health and preventive strategies. So practice is based on the concept of prevention. So promotion, protection, maintenance, and restoration of worker health, prevention of exposure to occupational and environmental safety hazards. So just as a little heads up, I do have a test question that I really like, so I'll probably continue to use it as I'm going through kind of tweaking test questions. But I do have a question about a hospital and what would an occupational health nurse find in going around a hospital. So of course I can't tell you what the question says, but I'm just kind of giving you a heads up that to expect a question that has some abnormalities that the occupational health nurse would need to be aware of, and what could we have to know, I guess, the difference between what would be hazardous in our environment and what would not be hazardous in our environment. So just a little heads up. Okay, so again, prevention of exposure to hazards, so thinking about biological, infectious hazards. So think about all the infection control measures that we take. Huge important in a hospital. Chemical hazards, environmental, physical, and psychosocial hazards. So psychosocial hazards, that's kind of an interesting topic, and I do think that violence towards healthcare workers probably fits under here. So I could talk about that for about an hour, but I won't. But I do think that that's an area that we as nurses need to really focus a lot more on. It's getting a lot of attention for sure in the media when nurses are hurt on the job, and whether to sue or not to sue. A lot of people have differences of opinion, but when we're thinking about nursing care and the hazards that go along with being a nurse, we really shouldn't be going just by opinion. We really need possibly legislation to help us with this issue. It is a very difficult issue, and if you poll 10 nurses, you're probably going to get 10 different ideas on how we should handle those types of situations. So possibly a psychosocial hazard could be harm, either verbal or physical, from a patient. Certainly could be bullying from other professionals too. So sometimes there's nurse-to-nurse bullying, there's doctor-to-nurse bullying, all those types of things that can make the work situation just really extremely difficult. So Healthy People 2020 and occupational health. So of course there are goals related to that. So occupational safety and health, work-related injuries and deaths, repetitive motion injuries, homicide. That's interesting that homicide is in that list. I think that's very interesting. Assault, lead exposure, skin disorders, and stress, and also hearing loss. So some of these are typical things. Repetitive motion, skin disorders, stress, hearing loss. Boy, I'm just really having a hard time with why homicide is in there. So, okay. Anyways, so it's good that Healthy People 2020 has goals related to occupational health. So examples of skills and competencies of the occupational health nurse. They have to manage the total worker health independently and with other team members, but truly they are more than likely the only medical professional on site, but they do have to work with other people in that facility. They plan, implement, and evaluate occupational health and safety programs and services for the target population. They practice nursing ethically and within the legal scope of practice. They have to stay current with evidence-based occupational health practices and demonstrate an understanding of the business climate and its impact on the health of the community. So skills and competencies, some examples. They work with interdisciplinary teams, manage budgets, practice culturally appropriate evidence-based care within a licensed scope of practice. That's an interesting thought too, culturally appropriate. So I know I have another test question that I really like, and it has to deal with possible cultural differences of people in the workplace. You're going to like that question. It's really a good one. Of course, I can't tell you what it is again, but just do be prepared that there is going to be a question about culturally appropriate, how to handle, and it's something that you probably will be able to get quite easily. Other skills, the nurse gathers information related to occupational health history, conducts and informs decision-making regarding fitness for duty and return to work. So that's certainly an important aspect. So if the person is physically able to perform the task, and if they have been injured, when they are actually able to come back to work and perform their duties safely. So they provide education and counsel on strategies for risk identification and elimination. So again, really kind of an interesting, unique position. And of course, like the example I gave you of a friend of mine, really depends on where you work as far as what your employer is wanting you to do or not. Again, this person felt their hands were really tied to do more prevention, counseling, and teaching. We always have to think about federal legislation with different aspects of nursing. So just a few things that I know that you have heard of. I'm sure you've heard of OSHA. So employers must furnish a place of employment free from recognized hazards that are causing or likely to cause death or serious physical harm to employees. Very, very important that this exists and that somebody is watching over, and that employers aren't just trying to cut corners or make things more economic for them, and not regard the health of their workers. So very important that we have OSHA. Workers' Compensation Acts, they're state-based, but they provide income replacement and health care for employees who sustain a work-related injury or possibly death. So they would be able to give some compensation. Americans with Disabilities Act, employers must make reasonable accommodations to enhance opportunities for individuals with disabilities, prohibits discrimination on the basis of disability. And we're going to talk a little bit more about that when we talk about Learning Plan 11, in which disabled people are considered one of the vulnerable populations that we're going to be discussing. What is a reasonable accommodation? It's in quotes kind of for a reason, because it really gives the employer a little bit of leeway. So if the employer has to perhaps make a $50,000 renovation to their company in order to accommodate the individual with a disability, they probably then, according to this act, don't have to do it. Reasonable accommodations wouldn't require somebody to be spending an enormous amount of money to do a workplace renovation to accommodate hiring one person. But if they were able to make a reasonable accommodation by perhaps maybe they have to spend a couple thousand, maybe $3,000 to do something, widen a doorway, or create a bigger cubicle that the person could get in and out of easily with a wheelchair, something like that would certainly be considered a reasonable accommodation. Okay, now we're talking about home health and hospice. So that includes a wide range of healthcare services provided to people in their homes to help them through an illness or injury. So that's basically home health. And then hospice focuses on caring for people facing a terminal illness with the goal when the goal is no longer curing the disease. So basic definitions of home health and a basic definition of hospice. Home care, there definitely is a growth in the home care market. There's a lot more people, increasing proportion of people aged 65 and older. Lower average cost of home health care compared with institutional costs. So much cheaper to keep somebody at home with services than to go into a rehab facility or a nursing home. Active insurer support for home care. So insurance companies sometimes will pay for home care more readily than they would the person going into an institution. Medicare promotion of home health care as an alternative, again, to institutionalization. So, and Medicare certainly kicks in when somebody is 65 or older. So the purpose of home health care services is to provide nursing care to individuals and families in their home. They receive referrals from many different sources, possibly from the physician, nurse practitioner or midwife, hospital discharge planner or case manager, teacher, clinic health care provider, or the patient's family also can make that referral. And the nurse identifies referrals to the community services and also performs referrals outward as necessary. It's really interesting providing care for somebody in their home. Maybe some of you have been a CNA doing some type of home care. Certainly some students have done that in the past and have told me about it. So it really is a unique opportunity because you are in their environment. So that's the big difference between having them in the hospital when that's your environment. Now you're in their environment. So really does lend a whole different aspect to nursing care. You have to understand and respect that you are in their territory. I had the opportunity when I was in school. I went through a bachelor's program only because the 2-year ADN program actually had a waiting list of 3 years long, so I didn't want to wait for that, so I went for the bachelor's right away. But we had a rotation in community health, and we were able to make home visits, and that was really a fascinating part of my education. We went without an instructor, although the instructor would from time to time make an appearance and just kind of check on how things were going. But of course, we had a list in mind, and we had to basically detail what we were going to do for that person, what they needed, and what we were going to actually do for them, what assessments we were making, and what interventions we were going to be doing. All that was kind of figured out ahead of time, but it really was interesting being in somebody else's environment. I do remember one elderly lady that I visited. It just wasn't a very nice neighborhood in Rochester, New York, in the city. I could tell just by going into the building. It was a little, kind of older, run down, and not in a great part of town. So I went in there, and this little lady was telling me about how she slept with a knife. She had a big knife under her pillow because she was so afraid of somebody coming in and attacking her. So, when you have experiences like that, it really makes you think about how people live out there in the world, and that not everybody has a safe, secure, place to live. Another really interesting experience I had was I was supposed to go to this one lady's apartment and fill insulin syringes for her for the week. So I was sitting down doing this on her kitchen table, and I probably had some kind of I don't know, not exactly a sterile field, but kind of a clean field set up on her table. But anyway, so I started filling insulin syringes, and while I'm doing that, I'm chatting with her, and all of a sudden a cockroach went crawling across the insulin syringes. So sometimes you just have to keep your composure, because when you're in somebody's home setting, you just never know what's going to happen. So that's the part that's interesting and exciting, can be a little bit disconcerting at times. So anyways, so I continued to fill the syringes, and then my instructor decided to make a surprise visit. So my instructor sat down in one of the chairs in the family room, and all of a sudden I noticed that, so the three of us, myself, my instructor, the patient, we were all sitting in her little family room talking, and all of a sudden I looked over at the chair that my instructor was sitting on, and a cockroach was crawling up the side of the chair. So that really gave me a very unique decision, like, should I do something about this? Should I say something, or should I not? So guess what I did? Nothing. I did nothing. So anyways, maybe you're laughing at me thinking, oh my goodness. But I decided that it probably wouldn't be a really good idea to kind of make this lady embarrassed about having cockroaches in her home, and kind of making a big deal about a cockroach, crawling up the chair. So I actually didn't say anything. So maybe that was a good idea. Maybe it wasn't. But anyways, my point is that it's really, truly a fascinating experience. You may find all different types of lifestyles, cultural challenges, or perhaps cultural practices that you're not familiar with. You can learn so much by being in somebody's home environment. It is just truly, truly fascinating. Okay, special home health programs. Patients who require continuous skilled care in an acute or a skilled nursing institution are able to return to their homes and receive care at home. So that's beneficial to the patient's health, to be in their own environment. Just think, if you've ever been in the hospital, how you just probably can't wait to be at home in your own bed with your own food in your own refrigerator and your own surroundings. It makes everyone feel better to be in their own environment. And it certainly is less costly than hospitalization. And the other benefit to the person's health is that they are closer to their support systems. So But family or caregiver support absolutely determines success. So if you don't have a supportive caregiver, that could make it very difficult to be at home. If you have somebody who is unable, unwilling, doesn't want to, for whatever reason, help out or do the things that are necessary, that can really determine the success or failure of how things go. So some examples of high-tech services that can be delivered in the home: daily infusions of TPN or antibiotic therapy, pediatric services for kids with chronic health problems, follow-up for premature infants at risk for complications, ventilator therapy, and home dialysis programs. So I actually had experienced myself the follow-up for premature infants at risk for complications. 26 years ago, I had a premature baby, and he was delivered by an emergency C-section and had a little bit of complications, not horrible, but was in the intensive care unit for about 9 days or so after birth, and he was, pretty small. So I remember getting home visits, so they must just trigger whenever you have a preemie, they just trigger these visits. And even though I was a nurse, somebody still came to my house. I remember this person coming and assessing my home situation. So I thought that was really interesting. And I just remember kind of walking around and the nurse making comments like, "Oh, how nice that you're talking to your baby all the time." Well, of course I am. Who else am I going to talk to? I have nobody else at home here with me right now. Anyways, I just thought that was pretty funny. But but she made, different, I remember her just making different comments about different things that she noticed, and mostly they were positive comments about things that she thought that I was doing well to promote the health of this premature baby. So certainly, I being a nurse, I probably didn't really need that type of service, but it certainly was nice to have somebody, I guess, just come and validate that she thought I was doing a good job. But I could see where that would be extremely important for somebody perhaps who didn't have a lot of knowledge or skills in taking care of the complex needs perhaps of that newborn baby, especially a preemie. Hospice home care. So you can have hospice in a facility like Sharon Richardson in Sheboygan Falls, or you can have hospice care delivered at home. You can have it in a nursing home. So there's a couple of different settings where you can have hospice. So hospice home care improves end-of-life care for the terminally ill. The goal is really to relieve suffering throughout the illness. It really supports the patient and the family caregiver through the dying process. So a lot of support for the patient, but absolutely for the people that are caring for that terminally ill person. And they also provide grief support to the family after the patient has died. And sometimes it extends a lot longer than you think it would, 6 months, a year and a half, almost 2 years. And sometimes they're still, making follow-up phone calls or sending things through the mail, really wanting to check and make sure that the family member is okay, which truly is a wonderful thing, because if people are grieving, sometimes it's really hard for them to reach out and get that support. But if somebody reaches out to them, they may more readily participate in that support. So caring for the caregiver is extremely important part of hospice. So you have to really assess, the nurse is in a good role to assess the caregiver's mental and physical health. Caregivers are at increased risk for developing mental and physical health problems. All decisions regarding care are made considering the health of the caregivers. So if a caregiver is absolutely completely burned out, they don't have any help, then perhaps the best decision might be to encourage them to have that person transferred to a hospice facility or a nursing home rather than stay at home. But of course it has to be that caregiver's decision, but certainly the nurse could be instrumental in trying to point out the ways that caregiver is really struggling. And interventions are directed towards preventing decline in that caregiver's health. We really want to, protect that person as much as possible. And of course, a big part of hospice care is pain control and symptom management. So we always have to remember the patient's pain is whatever he or she says it is, regardless of the nurse's objective evaluation of the situation. And I really especially believe this in terms of the person that is terminally ill. In other settings, such as med-surg or even on mental health, when we deal with patients that have chronic pain issues, honestly, I truly think that a lot of people simply don't really have a good understanding of what the pain scale actually entails, and I don't think it's always used correctly. And I know that you're taught, I'm sure in med-surg you're taught just, whatever the patient says, that's what you go by. But when somebody says they have a 10, to me, a 10, they would be having difficulty breathing, they would be doubled over, they would be possibly gasping, crying, screaming, something, So when somebody has a pain of a 10 and they're walking around, drinking coffee, talking to other patients, like sometimes they are on the mental health unit, you just wonder if they're truly using that scale correctly. So going off on a little bit of a tangent, but anyways, I'm not trying to go against what you've previously been taught. I'm just saying that I don't think that all patients truly understand the pain scale. They may think they have to say that they're at a 10 in order to get their medication. In a hospice situation, absolutely, whatever the patient says, we're truly trying to make them comfortable. So meds are given in doses sufficient to keep them free of pain, administered on a regular basis. They should not be having to ask for pain medication. They really should be given medication around the clock to keep them comfortable, because if you wait too long, then perhaps the pain is going to get out of control. The other thing that's just a little interesting side aspect of this is I remember when my mother-in-law was in hospice, they would be giving her, I think it was Ativan and morphine in liquid form, and they would just put the drops in her cheek and kind of let it absorb into the mucosa. But she was also on constant suction in her stomach because of nausea, and she had a bowel blockage, so she had to have continuous suctioning. The nurse was supposed to turn off the suction machine for at least like half hour or so in order to let the medication absorb and then turn the suction machine back on again. There was a couple of times when they forgot to turn off the suction machine, so the medication that was deposited in the membrane basically just got sucked right back out again. And I remember a couple of times where she really experienced some pain that she shouldn't have because the nurse forgot to turn off the suction. So just some things for, nurses really have to make sure they're monitoring the situation very carefully. They also help manage other symptoms: nausea, vomiting, constipation, diarrhea, fatigue, decreased appetite. So they're really trying to just help that person to live their life as comfortably as possible for as long as they are going to live. They provide a lot of emotional support to the patient and to the family as they adjust to the patient's impending death. The hospice nurse has to also think about cultural differences related to death and dying. So there are lots of different beliefs, attitudes, and values about death, and some of those are very cultural. Dying, grief, and loss are influenced by society and culture. So the nurse really needs to be very aware if it is a person who has a culture different from their own, to really try to understand their values, beliefs, and attitudes about death and dying process. Many individual differences exist even within a cultural group. So just because somebody is of a particular culture doesn't mean that they are automatically adopting all of those beliefs, attitudes, and values. So again, the nurse needs to really communicate and find out what that particular person believes. We need to ask the patients and families about beliefs and practices to avoid generalizations and ensure nursing care is patient-centered and culturally sensitive. So again, think of CUSN, patient-centered care. Now, the faith community nurse. So based on holistic nursing practice, the faith community nurse improves health of the community by implementing different roles or functions, being a health educator, personal health counselor, referral agent, health advocate. They may coordinate volunteers, develop support groups, and integrate health and healing. So the role of a faith community nurse actually came about, I think it was in the 1980s, 90s, somewhere in that time frame. And I remember when it first came out, and it was just a huge push to try to get as many people trained in this specialty area as possible. Again, you don't need to go back to school to get an additional degree, but it's more of a certification process with classes that you would take that would lead towards a certificate, again considered like professional development type activities. So I do remember a big push. And the problem with this is an awesome role for a nurse to take. However, the problem is that many faith communities, many churches simply don't have the money to pay for a nurse to be in this type of role. I know that was the case with my church. There were 3 churches that kind of worked together, and we did have a faith community nurse several years ago, and it got to a point where there was simply no more money in the budget to fund her. But she had an awesome role with trying to help people with many different aspects of care, and all provided right in the church setting. So the faith community nursing role in health and wellness. Through history, churches have provided care for the indigent, poor, disenfranchised, meeting their basic needs and basic health care. So it does have some historical basis. Many religions have traditions and rituals related to health and healing. Some religions give specific guidelines for ministering to the ill, homebound, or dying members. All major religions describe the relationships among health, healing, and wholeness. And the faith community nurse needs to understand the importance of spirituality. And of course, then communicating with the patient or groups of people and to understand their own specific values and beliefs. So, some issues in faith community nurse practice. They work with vulnerable populations. Sometimes they develop programs for homeless individuals and their families, refugees, low income. There's legal and ethical issues of confidentiality and accountability. So the faith community nurse is not required to follow HIPAA because congregations are not identified as a health provider, but they do share confidential information with other church ministry leaders or prayer groups with the client's permission. So the most important word there would be with the client's permission, because truly, if you were a faith community nurse and you would tell lots of different people about a particular person's health issues or a family's health issues, or even a family's, perhaps they have poverty and they have needs that maybe they don't want other people to know about, and if you're kind of breaching confidentiality that way, perhaps you're not bound by HIPAA, but certainly you're not going to be held in very high regard as far as your your ability to be a professional. So that certainly could be an issue, and it would probably be very difficult for people to use your services if they did not feel that you were a trustworthy individual. So usually certainly the permission of that person should be granted, whether or not you're required to follow HIPAA or not. So the end of life, understanding hospice and palliative care would be an important part of that faith community nurse, because that person could be providing a lot of support for the patient and also, again, for the family member. They have to understand family violence issues. They really need good assessment skills related to identifying individuals and families that are at risk for violence. So somebody may be very comfortable talking to somebody in a faith community church type setting about an issue at home, and so that nurse really needs to have a basic understanding of basically everything that we talked about in Learning Plan 8. So, and I think that this might be the last slide for this learning plan. Everybody, all areas need we need to go by ethical principles. So it is, again, a competency, so we need to just talk really quickly about ethics in healthcare, and there's 4 basic principles. I also believe that there is a question in your discussion question that's related to ethics. Maybe it's in the next learning plan. Well, anyways. Okay, so autonomy is the patient must be allowed to make his or her own decisions. So the healthcare provider, the nurse, certainly can encourage people. We can certainly advise people, but we can't make people to do things that we want them to do. We really need to empower people, give them the information, and they really have to be allowed to make their own decision. We should not be forcing people to act a certain way, to take a certain medication, whatever. There is that principle of autonomy. So very important to keep that in mind when we're working with patients. Beneficence means all procedures and treatments recommended must be with the intention to do the most good for the patient. So that's really what beneficence means, to do good. So whenever we do any type of nursing care intervention, our goal should be to do good for that person. Non-maleficence is basically do no harm. So I think you've probably heard that before, and many times we relate it to doctors and the Hippocratic Oath, but truly it is meant for all healthcare professionals and certainly nurses to do no harm. So we have to consider whether other people or society could be harmed by a decision made, even if it's made for the benefit of an individual patient. That's part of that non-maleficence. But also when we are working with the individual person, to make sure that whatever we do, what our interventions are, that we are not causing harm to that patient. And then the last principle is justice, which basically is fairness in decisions that burden and benefit, as well as equal distribution of resources and scarce resources especially, and new treatments. So are people having equal access to have a new treatment or a new medication, or are just the rich being able to afford this, and people that are poor that don't have insurance or don't have good insurance, they're not able to partake of this particular new treatment. So that's what the ethical principle of justice is all about. Okay, well, that's the last part of Learning Plan 10. I will see you for Learning Plan 11.